Most people who get a stent put in think the hard part is over. And in one sense, they're right. The blockage is open, the blood is flowing, the crisis has passed. But here's what almost no one talks about. What happens in the first 12 months after that procedure determines whether you stay healthy or end up back in an operating room. And the second thing almost no one tells you, a stent is not a cure. It is a fresh start. What you do with that start is entirely up to you. If clear, honest health information is something you want more of, subscribe and hit like right now. It takes 2 seconds and it helps this channel reach more people. Here on Dr. Waterling, the goal is 200,000 subscribers, and every single one of you is part of making that happen. Practical checklists and health posts go out on my Telegram. Look for the QR code on screen right now and scan it. Let's go back to the beginning, because understanding what a stent actually does starts with understanding what went wrong in the first place. Your arteries are essentially tubes. They carry blood from your heart to every organ in your body. When those tubes are clean and open, everything works the way it should. But over years, sometimes decades, a substance called plaque builds up on the inner wall of the artery. Plaque is a mixture of cholesterol, calcium, fat, and inflammatory tissue. It doesn't accumulate overnight. It builds slowly, silently, the way a pipe furs up over years of use. The medical term for this buildup is atherosclerosis, which simply means hardening and narrowing of the arteries due to plaque. As the plaque grows, the opening inside the artery gets smaller. When that opening is reduced by about 70%, the heart muscle starts struggling to get enough blood during exertion. That's when you feel chest tightness or pressure during physical activity. That condition is called angina, stable angina specifically. It means the artery is severely narrowed, but it hasn't closed off completely yet. Now, if that plaque ruptures, if the outer surface of it tears, the body reacts the way it always reacts to a wound. It sends platelets to form a clot. In a normal cut on your skin, that's a good thing. Inside a coronary artery, it is a catastrophe. The clot forms on top of the ruptured plaque, and the artery closes off completely. Blood stops reaching the section of heart muscle that depends on that artery. That is a heart attack. The medical term is myocardial infarction. Myocardial means of the heart muscle. Infarction means tissue death from loss of blood supply. Here's the part that matters most: time. If the artery is reopened within roughly 4 to 6 hours from the onset of chest pain, the majority of heart muscle cells can be saved. But if 12 hours pass with the artery still closed, most of those cells are dead. They don't regenerate. They're replaced by scar tissue. That scarring can eventually cause a bulge in the wall of the heart called an aneurysm, a weakened, non-functioning pocket that permanently reduces the heart's efficiency. This is exactly why the stent exists, and why the timing of its placement matters so much. The first coronary stent was implanted in France in 1983 by 2 physicians, Puel and Sigwart. That original device was crude by modern standards, a bare metal scaffold, nothing more. But it worked well enough to open a blocked artery and keep it open. Over the following 40 years, stent technology went through a transformation that is genuinely remarkable. Today's coronary stents are not just metal scaffolding. They are coated with a polymer, a thin, flexible layer of material that contains a drug called a cytostatic agent. Cytostatic means it slows down cell growth. That might sound counterintuitive. Why would you want to slow down cell growth inside a healing artery? Here's why. When the first bare metal stents were implanted, a significant percentage of patients experienced something called in-stent restenosis. Restenosis means the artery narrows again, not because of new plaque, but because the body's healing response sent too many cells to grow over the metal mesh, eventually blocking the opening again. This was especially common in patients with diabetes, whose cells tend to proliferate more aggressively. The drug in the polymer coating solves this problem. It releases gradually and precisely into the surrounding tissue, keeping the cell growth just controlled enough that the stent stays open, without interfering with the normal process of the artery healing over the device. Modern drug-eluting stents have reduced restenosis rates dramatically. This is not a minor improvement. It changed the outcomes for hundreds of thousands of patients every year. A well-documented pattern in interventional cardiology goes like this. A man in his late 50s, call him Robert, comes in with increasing chest pressure whenever he climbs stairs. Stress testing confirms significant coronary artery disease. He undergoes stenting of a major artery, and within days, the pressure he's been living with for years is simply gone. Robert feels so good, so fast, that he starts to wonder if maybe he can ease up on his medications. That decision, made quietly and with the best intentions, is where many post-stent stories go wrong. We'll come back to Robert in a moment. A common fear among people who've just had a stent placed is that the device might shift or migrate inside the body. This concern is understandable. You've got a small metal structure inside a major artery, and the heart is always in motion. But here's what actually happens during implantation. The stent is mounted on a thin balloon catheter. That catheter is threaded through the artery to the site of the blockage, guided by imaging in real time. Once it's positioned correctly, the balloon is inflated to somewhere between 10 and 16 atmospheres of pressure, which is significant pressure, and the stent is expanded forcefully into the artery wall. It doesn't rest against the wall, it is pressed into it. Interventional cardiologists also use intravascular ultrasound, a tiny imaging probe inside the artery, to confirm that the stent is properly sized and fully opposed to the vessel wall. The stent is matched precisely to the true diameter of the artery. It becomes essentially a permanent structural part of the artery wall. It doesn't drift, it doesn't float, it is mechanically fixed in place. There is an interesting distinction between coronary stents and the ones used in other locations, like the carotid artery in your neck or the iliac artery in your pelvis. Coronary stents, the ones placed in the arteries of the heart, are designed with a specific balance between radial strength and flexibility. They resist the constant squeezing of the heart muscle without breaking or kinking. However, they are not completely rigid, and with extreme force, they can be deformed, which is precisely why stent placement in the coronary arteries is always carefully chosen to avoid locations where the vessel is under significant mechanical stress. Stents placed in the carotid or iliac arteries, on the other hand, are self-expanding and essentially crush-proof. You can compress them and release them, and they spring back to their original shape. This design is intentional. Those vessels move with the body, flex with posture, and need a device that can handle that without losing its shape. Now, back to Robert and to the single most important thing you need to understand about life after a stent. When a stent is first placed, the body recognizes it as a foreign object. That recognition triggers the clotting system, the same mechanism that would respond to a splinter or a cut. Platelets, the small blood cells responsible for clotting, begin gathering around the metal mesh of the stent. If that process isn't controlled, a clot can form inside the stent, closing it off. Stent thrombosis. And when a stent thromboses, the result is usually a full heart attack, often more severe than any chest pain the person had before. The way modern medicine prevents this is with something called dual antiplatelet therapy. Dual means two medications taken together. Antiplatelet means the drugs prevent platelets from clumping and clotting. The two medications most commonly used are aspirin, typically at a low dose of 75 to 100 milligrams, and a second agent, either clopidogrel or ticagrelor. Both work on different platelet pathways, which is the point. One drug blocks one mechanism, the other blocks a different one. Together, they give the body two separate reasons not to form a clot on the stent. Think of them as two separate locks on the same door. The reason this matters so deeply is timing. In the first weeks and months after implantation, the stent is gradually being covered with a new layer of cells, the same type of smooth endothelial cells that line a healthy artery naturally. This process is called endothelialization. Once the stent is fully covered, typically over the course of about 12 months, it is essentially incorporated into the artery wall, and the clotting risk drops dramatically. But until that process is complete, the stent is vulnerable. This is why skipping even a single day of antiplatelet medication in the early months after stenting is genuinely dangerous. One missed dose does not give you a cushion. There is clinical data and a hard-learned lesson from years of cardiology practice that sudden discontinuation of dual antiplatelet therapy in the early post-stent period is one of the most common triggers of stent thrombosis. The clotting system, which the drugs have been suppressing, rebounds quickly, and a stent thrombosis is a medical emergency. A pattern that comes up in emergency cardiology more often than people realize. Someone who had a stent placed 8 or 10 weeks earlier felt completely fine, and quietly stopped one of their medications because they ran out or didn't think it was that important. They present to the emergency room with a massive heart attack, the one the stent was supposed to prevent. This is Robert's story, and it plays out in hospitals across the country more than it should. After 12 months of dual therapy, and this is always a conversation between you and your cardiologist, not a decision to make alone, many patients transition to aspirin alone as long-term therapy. Some may require longer dual therapy depending on their individual risk, but the first year is non-negotiable. Now, the stent addresses the consequence of atherosclerosis. It doesn't address the cause. And this is the part of the conversation that often gets lost in the relief of surviving a cardiac event. The plaque that blocked your artery formed because of a combination of factors. Elevated LDL cholesterol. LDL is the type of cholesterol that contributes to plaque buildup. High blood sugar, which damages artery walls and accelerates plaque formation. High blood pressure, which creates mechanical stress on those walls and makes them more vulnerable to injury. Smoking, which directly injures the endothelium, that inner lining of your arteries, and promotes every stage of atherosclerosis. These factors don't disappear because you have a stent. If they continue unchecked, plaque will continue to build in the stented artery, around the edges of the stent, or in other arteries entirely. The risk of needing another procedure is real and measurable. It is not inevitable, but it requires active management. Medications to lower cholesterol, statins primarily, are almost always part of post-stent care. Managing blood sugar is equally critical, particularly in people with diabetes or pre-diabetes, because elevated glucose accelerates arterial damage in a way that no stent can compensate for. Blood pressure control, smoking cessation, and regular physical activity all directly reduce the rate at which new plaque forms. These are not optional lifestyle extras. They are the medical continuation of what the stent started. And about physical activity. This is an area where fear holds a lot of people back unnecessarily. If you had a stent placed for a stable angina or an early cardiac event, and you don't have a ventricular aneurysm, and your heart function has been evaluated and is reasonable, most people can and should return to regular exercise. Walking is always a solid starting point. In many cases, with proper evaluation and guidance from a cardiologist, people return to running, cycling, and other sustained aerobic activity. Exercise is not just permitted, it's part of the treatment. It improves the function of the endothelium, lowers blood pressure, helps regulate blood sugar, and reduces cardiovascular risk across the board. The details of what level is right for your specific situation are something to work through carefully with your care team, but don't assume a stent means you have to be sedentary. Often the opposite is true. Something that comes up regularly in cardiac rehabilitation settings, a woman in her early 60s, call her Patricia, who had a stent placed after years of exertional chest pain. In the months after the procedure, she was afraid to exert herself at all. She moved slowly, avoided stairs, stopped walking the neighborhood. At her 6-month follow-up, her cardiologist cleared her for a graduated exercise program. Within 3 months of starting, Patricia completed a 5-kilometer walk. She described her stamina as better than it had been in a decade. That's not unusual. It's actually the expected outcome when post-stent care is done right. This is also a good moment to address the cholesterol conversation because it is frequently misunderstood. After a coronary event or stenting procedure, the target for LDL cholesterol is more aggressive than in the general population. The general recommendation is to keep LDL below 70 milligrams per deciliter. That's a unit measuring how much cholesterol is in your blood. And for very high-risk patients, even below 55. Diet alone rarely achieves this after a cardiac event. Statin medications like atorvastatin or rosuvastatin are typically required, and the evidence supporting their use in this population is substantial. If you have concerns about side effects or tolerability, those are conversations worth having openly with your doctor. But the decision to manage cholesterol aggressively after a stent is grounded in decades of outcome data. Here's something that connects directly to all of this. How old are you? Age genuinely shapes almost every aspect of post-stent recovery, from how quickly the endothelium heals over the stent, to what level of exercise is appropriate, to how aggressively certain risk factors need to be managed. Leave your age in the comments. It's not just small talk. It changes the picture. So, what does living well after a stent actually look like in practical terms? It means taking your antiplatelet medications every single day without exception, especially in that first year. It means having a clear understanding of your cholesterol target and what you're doing to reach it. It means knowing your blood pressure numbers and keeping them in a healthy range. It means not smoking, and if you do smoke, making a genuine, supported attempt to stop. It means building physical activity back into your life, starting gradually and building on a timeline that your care team helps you define. And it means understanding that every follow-up appointment is an opportunity, not a formality. A stent is not a sentence. It is, as it has been said many times by cardiologists who see the full arc of these patients' lives, a second chance. 30 or 40 years ago, a blocked coronary artery often meant death or permanent disability. The options were limited: bed rest, blood thinners, and if the patient survived, a major open chest surgery called coronary artery bypass grafting, where a vein or artery from another part of the body is rerouted to bypass the blocked section. That operation required opening the chest entirely and putting the patient on a heart-lung bypass machine, a lengthy, high-risk procedure that is now reserved for only the most complex cases. Today, 1 in roughly 150 cardiac patients requires bypass surgery. The rest can be treated endovascularly, through the artery, with a catheter, without opening the chest. That shift in medicine happened within a single human lifetime. What you're carrying in your artery is the result of 40+ years of relentless engineering and clinical science. Use it well. Take the medications, manage the risk factors, keep the appointments, have honest conversations with your doctor about what you can and cannot do, and push for clear answers because you deserve them. Everything in this video is health information. It's here to help you ask smarter questions and understand the answers. It is not a substitute for the individualized advice of a physician who knows your case, your imaging, and your full health history. And no online video ever will be. If this video gave you something useful, subscribe and leave a like. Both take about 2 seconds and they make a real difference in how many people this channel reaches. 200,000 subscribers is the goal and every new one matters. For checklists and additional health posts, my Telegram channel is the place. The QR code is on screen right now. Scan it and you'll have it.